Good afternoon, dear listeners, highly respected experts and colleagues, and other guests who have joined us today for this project presentation, Erasmus Plus project between Israel and Latvia, where the main topic is patient care in case of polytrauma in pre-hospital settings. My name is Dagnija Vidomska. I will be manager of this event. I am glad to say that finally, after a few hard pandemic years, we are finally here, and as you can see, we have chosen the online format for this project presentation. A few things I would like to say. The first one is every listener have option to choose language. You can choose preferred language by finding the globe icon on your Zoom screen and by clicking on it. And the second thing is during the entire event, you're more than welcome and use this great opportunity to ask questions to all our experts, which will be answered few moments later. For now, I would like to give a word to Emergency Medicine Physician Assistant, Study Program Director, Viktor Gorovenko.
Dear experts, colleagues, friends, I am glad to have this opportunity to address you today on the occasion of reporting the progress of Erasmus Plus framework project between Red Cross Medical College from Latvian side and Galilee Medical Center of Bar Ilan University from Israel side. Let me first introduce myself, and then I'll give you a concise outline of what we have achieved in the project thus far. My name is Viktor Gorovenko, and I am anesthesiologist and reanimatologist. My daily work revolves around emergency medicine. As part of a special care unit, I work in State Emergency Medical Service of Latvia. As a doctor, I work one of the biggest hospital in Latvia, as well doing teaching and research. But here today I represent Red Cross Medical College of Riga Stradiņš University, where I am program director, emergency medicine physician assistant study program. As you might know, the original idea of having an experience exchange trips, lecture as well as practical exercise, conceived 2 years ago. Unfortunately, due to COVID-19 pandemic, we had to make adjustment to our original plans. Instead of postponing the implementation of project, we decided to seek out other options. Thus, in cooperation with State Emergency Medical Service of Latvia, we create a short educational film for polytrauma patient management. We focus on the pre-hospital phase of medical response. I'd like to offer you to watch this film in order to introduce a round of discussion about its content. Also, it's given that topic is covered by international guidelines, we understand the importance of experience and traditionals based on understanding and interpretation of some important details. We especially welcome comments from our Israel colleagues given their great experience in care of severe trauma patients in civilian and military conflicts as well. Let's have an interesting and valuable event. Thank you very much.
Thank you, Viktor. And for now, I would like to give a word as well to Director of Riga Stradiņš University, Riga Red Cross Medical College, Ināra Upmale.
Tātad, labdien, cienījamie diskusijas dalībnieki, dāmas un kungi. Es jūs sveicu Rīgas Stradiņu Universitātes Sarkanā Krusta medicīnas koledžā. Šodienas diskusija ir teicamās sadarbības rezultāts starp Rīgas Stradiņu Universitātes Sarkanā Krusta medicīnas koledžu Latvijā un Latvijas Universitāti Izrēlā Erasmus Plus programmas ietvaros. Paldies abu valstu ekspertiem diskusijas virzīšanā. Vēlu visiem ļoti interesantu pieredzes apmaiņu, un kas noteikti bagātinās katru šodienas diskusijas dalībnieku pieredzi un veicinās kompetenci pilnveidu politraumas pacientu aprūpē. Lai šodien ir interesanta diskusija, lai visi iegūstam interesantus rezultātus. Paldies!
Thank you, Inara. As we go on with the film presentation, I am honored to introduce you all to our project experts, both from Latvia and from Israel. From Latvia side of the project, we have Igor Ivanovs. Igor Ivanovs is Associate Professor of University of Latvia, Chief Surgeon in Riga East University Hospital, Department of General Surgery and Emergency Surgery, and he has experience more than 20 years. The next one is Slava Gorovenko. Dr. Gorovenko is anesthetist and intensive care specialist, special interests in emergency medicine in pre-hospital stage and regional anesthesia. Dr. Gorovenko has 6 years UK experience at different levels, including 2 years consultant post in Manchester. Currently, he is working at Trauma and Orthopedic Hospital and Riga Ambulance Service as a consultant. The third expert from Latvia is Ivan Krupenko, a medical doctor, certified orthopedic trauma surgeon at Riga East University Hospital, Orthopedic Trauma Department, Polytrauma Unit. He is also Riga Stradiņu University Orthopedic Department lecturer and lecturer at Latvian Red Cross College. He specializes in work with admitted patients in emergency room who have severe trauma after traffic accidents, fall from heights, blast injury, gunshot wounds, and disasters. And now I would like to continue with our Israel experts. The first one is Eli Kakiashvili, a chief of general surgery, Galilea Medical Center, director of MIS Simulation Center, Galilea Medical Center, chief of general surgery, Faculty of Medicine, Bar Ilan University, and coordinator of Israel chapter of TUGS, the International Society of Upper Gastrointestinal Surgeons. The next one is Dr. Daphne Wilner, chairman in the Department of Anesthesia and Operating Theatre, Galilea Medical Center, fellowship, neurosurgical anesthesia, head of committee, anesthesia, Israeli School of Medicine, Bar Ilan University, specialized in research in neuroscience, including neurotrauma, very enthusiastic about resident education and runs a national 3-day workshop for preparation for the anesthesia boards, treasurer of Israel Anesthesia Society. And the third one is, my apologies. And the third one is Professor Alexander Lerner, medical doctor and PhD, Department of Orthopedic Surgery at Ziv Medical Center, Zefet, Israel, Faculty of Medicine, Bar Ilan University as well in Israel, and he has more of 40 years clinical experience in field of reconstructive orthopedic surgery, correction of limb deformations, treatment of non-unions and malunions, limb salvage after extensive tissue loss, management of severe trauma, including bar injuries, chronic osteomyelitis, limb reconstruction and elongation. and more than 75 publications in field of trauma, orthopedic and reconstructive surgery. Pleased to meet you all. So I think we can continue with the movie presentation. At the beginning, you will see a full video material, which will be followed by review of separate parts of it, of each case. And after that, there will be discussion, experience exchange, and opinions with the experts. And in this full video material, you will be introduced with primary survey, immobilization technique, secondary survey in the ambulance car, and management of different emergency cases. So let's continue with the movie presentation. beginning, I would like to refer to our Israel colleagues and experts, and I would like to ask, what is your first impression about what did you just saw? Dr. Ali, can I ask you your first impression?
Yes, thank you. First of all, thank you for invitation. I'm glad to be here. It's a really great honor. It's a very nice video. In reality, it's a little bit different. I have some questions, please, before I'm giving to you my opinion. What individual, the personnel, they are treating patient? Who are those people? Medical doctors, nurse, paramedics?
Okay, thank you for your question. There are emergency medicine physician assistants.
I'll tell you why I'm asking, because in our country, for example, the system is a little bit different. As a doctors, we are not involved in pre-hospital treatment of patients. Usually, who is going to accident patients, they are paramedics and you know, the people they are working on ambulance. We do have some experience in pre-hospital treatment as a military doctors when we are doing army service, because in battlefields, when we have injured patients, in military ambulance, we do have doctors. So it's a little bit different system. I remember the former Soviet Union countries, it was a little bit different, because in each ambulance, they had doctor, I remember. In Israel, it's a little bit different. So the first job who does, it's paramedics, okay? Now, another questions, as I mentioned, we have some experience in pre-hospital treatment as a military doctors. For me, it was a little bit strange, the procedures like vein access and intubation, everything was done in video in ambulance.
Okay.
It's a little bit strange, because in ambulance, when you have a very tiny place, and same in helicopter as well, there is no indication to do procedures like this. So we are a stabilized patient in the field, and then we are going, and system, approach we are respecting in Israel, at least it's a scoop and run. So to get patient as soon as possible to hospital. And the average time in Israel here, it's 40 minutes. If it's above 40 minutes, it's actually indication to invite helicopter from army service and use this way to get patients to hospital. So I know it's a little bit different because we are small countries and we have pretty high number of hospitals. So the average time it's 40 minutes. But again, all those procedures like intubation, vein access, and examination of patients must be done outside of ambulance or helicopter.
Okay,
because technically it's undoable to do when ambulance is starting to driving. You cannot do those procedures.
Okay, thank you. I think the details like intubation or other procedures we will discuss later about each part of the movie. It will be presented once again, and then then there will be like more details about each part of it, why and what are we doing and what are we not doing. Maybe Latvian experts can share your first impression.
So actually, yes, thank you. Actually, I think that maybe difference in our countries, it is because maybe my colleague have more experience in this, because other people can see it, yes, and maybe it is not so good for other people that are in the field around, that they see what you are doing, and that's why you go into ambulance and do it in ambulance. Maybe you can commend it.
Dr. Gorovenko, do you have any?
You just mentioned that you're not doing such as procedures like intubation and venous access on an ambulance setting. So if we have losing the airway, we have to support the airway. So no chance to go from the scene to the hospital, which may take another 40 minutes with no airway at all, or venous access. So, so we're not doing these procedures on a moving ambulance. So the ambulance on the scene or in the ambulance. So, and it doesn't take really a long time. Daniel just mentioned about the system, how it works here. We've got, so most of our pre-hospital, let's say, assistant physicians, they are paramedics actually. So it used to be on every ambulance doctors. So now this situation has changed. So we've got such people like me who can support paramedics, which run fast car response, and if they need some extra help with the airway issues or hemodynamic issues or whatever they need, so they ask for help, and that's why we're here. So we're still doing the procedures. This needs to be done pre-hospital to save life. So we're not doing, let's say, spending a lot of time before hospital.
Maybe I was not clear. Of course, if someone has airway problem, you have to do intubation, airway access. Yeah. What I mentioned, all those procedures must be done outside of the ambulance, in the field, and then you are taking patient to the ambulance onto the helicopter. Yeah, that's what I mentioned.
I see what you mean, but we work where the patient is. So the patient might be on a street, or might be already on the ambulance. The patient in the ambulance, and let's say we've got winter, minus 25 degrees. We can't do anything on a street. So we need to get the patient on the ambulance, let's say. So.
This is a very interesting discussion, but I think we have to continue with separate parts of the movie, and after that we will continue this discussion. So let's watch the next episode. So thank you. And now let's discuss some details about primary survey. As we know, we are guided by the ABC principle, which means, as we all know, C is circulation, and in this case, it means we have to stop life-threatening bleeding, and then continue with airway, secure breathing, and once again circulation check. And I would like to refer this question to each of our experts. First of all, do everyone agree with tourniquet use? And all of you can share your personal experience with it and the pros and cons of tourniquet. So once again, for first I will ask to Dr. Eli Kakiashvili.
That's okay. Look, I mean, I would like to say like this: what is killing severe injured patient in the field? It's airway problem usually. So the first goal when we are starting to treat patients, we have to get airway. So on the video, when people are getting to the patient, I saw someone is pushing bleeding wound and other doctors trying to check what is the pulse. So it was not ABC, you know, so you have to ignore all injuries and firstly to try to figure out if patient has airway. So the easiest way, what we are doing, we actually asking to patients, what is your name? And if someone is able to speak, that means that airway is open, okay? Then we are starting to examine patients, and then we are starting to treat other problems. So if you have protecting airway, in my opinion, then you can move to other problems and you can put tourniquet. But of course, you are not starting your treatment by the tourniquet. The main issue in severe injured patients is airway problem.
Okay, thank you.
Particularly when you have multiple injured patients. I mean, a lot of patients when you are getting to field. So we are ignoring all the injuries, you know, and we have to protect airway problem.
Okay, thank you. Does everybody agrees with this opinion? Dr. Daphne Wilner, what is your opinion and experience about it?
So, thank you for inviting me to this interesting conference. I agree with Dr. Kakashvili. I think airway is an issue that has to be addressed immediately, because if your patient is not breathing, then he's going to have anoxic brain damage. So all your attempts at saving his life is not going to go very far if he doesn't have a brain at the end of the day. But here you have few people giving assistance. So yes, one can put a tourniquet. One certainly should assess if there's a carotid pulse or not. And at the same time, somebody can just put their hand over the patient's mouth and, like I said, or speak to the patient. Also, speaking to the patient also assesses the patient's level of consciousness and whether he has a patent airway. So I do agree with Dr. Kakashvili on the assessment of the situation. I have to say, though, there was a lot of time used for transferring and wrapping up the patient, something which I don't usually see. I've worked in 2 level 1 trauma centers, one in Israel and one in the States. The Galilee Medical Center is not a level 1 trauma center because it doesn't have cardiac services, but we get a lot of major trauma. I worked last night and we got five accidents. So I usually don't see so much time being spent on what I would want to call wrapping up the patient. I did want to say, though, to what Dr. Kakashvili said previously, when I was a resident in anesthesia, we worked on the ambulance services. Every ambulance service in the Jerusalem area had an anesthesia resident, okay, and there were doctors on the ambulances. Unfortunately, due to money issues, they stopped using doctors, but I personally, as a resident, I felt that I received quite a lot of important education from being on the ambulance.
May I say something also, please? I checked the time before in video doctors are taking patient to the ambulance. It was 80 minutes. And we know what is the diagnosis of this patient. We saw full video. It was tension pneumothorax. So this is a critical time. You can lose your patient, you know? So the time, it was very long before, you know.
Okay, thank you. And I would like to say that the diagnosis was not tension pneumothorax. It was like 4 different situations. Like for emergency, there was hypovolemia, tension pneumothorax, but it was not the diagnosis. It was just like to show how to manage the situation. It was not the only one diagnosis what was happened there.
Okay.
Okay, thank you. And Professor Alexander Lerner, I would like to hear your opinion as well about this primary survey.
Thank you very much. Okay, thank you very much for invitation. It's a great honor for me. Thank you for good idea to talk for polytrauma, for treatment approach. First of all, I think maybe a single negative moment, it's very slow walking from ambulance to patient. This is a severe trauma. We haven't time. The walking should be fast. Okay, I very like you start with cervical spine immobilization by cervical collar, and also long spine board is excellent because protection of spine, of cervical spine, of thoracal and lumbar spine should be all times until spine injury is excluded. So it's excellent. I very like transportation from the ground to gurney by stretcher. It was excellent, nice. Okay, for left leg. We start with treatment of bleeding wound of left leg. We start with manual pressure, bandage, and then tourniquet. If it's enough to stop bleeding with single bandage, you need a tourniquet. But in this particular case, it may be need tourniquet because the bleeding was continued after bandage. I think in this case of high energy multiple trauma, it's not single bleeding. It may be open leg fracture. And in open leg fracture, we need start as early as possible with antibiotic. Maybe here in urban condition, 15-20 minutes until hospital, you needn't, but sometimes even in countryside with long-term transportation, you need start also with antibiotic prophylaxis. In our practice, we like immobilization for broken leg with special splint. But in this case, it may be enough 2 legs together and a vacuum mattress. I think in this case, it was enough for the leg. About right lower limb. When you come to patient, the right leg was in some external rotation, and all time internal rotation, external rotation. This may be a sign of hip dislocation or even pelvic fracture. And here in this video, I can look some attention to this possible trauma. Maybe simple external rotation, but you need think for hip dislocation or pelvic fracture. And in this case, internal, gently internal rotation of leg, it's very positive moment, especially in open book fracture. It can diminish pelvic volume. it was very good fixation to stretcher, to gurney, together with mobilization, and no more comments. Generally, it was good. Thank you.
Okay.
And what's something I think it's very, very important to talk about treatment of severe trauma, especially today in war in Europe. So the trauma care is very actual, and I think it was excellent idea of our Latvian colleague to talk for severe polytrauma as in this case. Thank you.
Thank you. And now I will refer to our Latvian experts. Dr. Krupenko, can you share your experience and thoughts about what you just saw?
So I absolutely agree with Professor Lerner. In this case, probably we don't need the tourniquet to get it on. Just we can just get on this tourniquet, but don't pull it very, very hard, for example, or don't pull it at all. Probably it could be needable in the future when the patient will be in an ambulance on a secondary survey. And absolutely agree with this rotation of the right lower limb, because as we know, probably it could be, as the professor told us, the hip dislocation, hip fracture, open book fracture, and this splitting of the legs give us a little bit stability of the pelvis. Of course, if we are talking in the future, it could be used a teapot or some belts for the pelvic ring, especially if we have unstable patient and we don't have any reasons of instability. So we're just losing somewhere blood, because in these signs we see only probably there is a problem in the pelvic, because the blood loss of the pelvis in open book fracture could be 3.5 liters. And I absolutely agree, it's too long time for while they are walking to the patient, especially if it's polytrauma patients. And if we are talking about polytrauma, we're seeing the polytrauma patient, or it's just, for example, isolate lower limb trauma. Yeah? We should know what's going on there. What's the mechanism of this trauma, for example. And after that, we can talk about what we can observe with these patients, what kind of the diagnosis, and so on.
Okay, thank you. Do you have any ideas or suggestions how can it be done more quicker if it's too slow? How they went to the patient and everything was done like in 8 minutes, and you and other colleagues say it should be done faster. Do you have any realistic suggestions? Maybe.
First of all, we should walk faster.
Just walk faster.
To the patient,
yeah.
just not just walking by the street.
Do you mean we have to run to the patient?
Run,
okay.
of course, if it's possible.
Okay.
After that, all this command leader should command what they are have to do. Of course, this leader should be like a doctor or a paramedic who knows and can just by observing the patients just on the ground tell some probably injuries, and after that there will be some kind of algorithm in his mind.
I think we have algorithm. This is algorithm how this is working, and still you're saying this is too slow. Okay. Okay, Dr. Ivanov, your opinion about this discussion?
Yes. Actually, I agree with the whole experts, but I have some comments maybe to this situation. First of all, to this CABC, I think, I don't know, but actually I saw that in the beginning, this assistants doctor assistants, they speak with the patient, I think. So they assess so they assess airway, they assess consciousness, and I think it was in this video. But I cannot see point B in the beginning, because this breathing, checking airways, or not airways, but breathing with phonoendoscope, it was only in ambulance, and it should be in the beginning here, so like a second point, and they should find this if patient have this pneumothorax. So immediately, as a second step, because as Dr. Kakiashvili said, it is very dangerous situation. If it is possible a situation, we need to fix the situation immediately. So, and of course, about bleeding, I said that yes, in most cases we can manage bleeding by pressure and pressure bandage and tourniquet. Probably in this situation it is not necessary. Yes, of course we can do it, but it is not necessary, I think.
Okay, thank you. And Dr. Grovenka, as I know you are working in emergency medicine in this pre-hospital stage, of course with polytrauma patients as well. So what are you thinking about all our experts' opinions, and what is your experience with that? Do you agree or not?
Yeah, thank you, Dagny. A couple of words regarding the polytrauma patient approach. We're still using the ABCD, and we're trying to follow the guidelines and all recommendations. In terms of the airway assessment, so it's very natural just to ask for response. If you have no response, so there may be the airway problems, the first. If the patient got life-threatening bleeding, external bleeding, so which is arterial bleeding, so you put the tourniquet. In terms of the timing, 8 minutes to get the patient from the street fully mobilized on a stretch, it's not a lot, I would like to say. Maybe I'm wrong, but regarding the pneumothorax and checking the patient on a street, so you will be very lucky to get the right diagnosis of pneumothorax just listening to the chest. So we know the best approach to diagnose pneumothorax is ultrasound or chest X-ray. So if you've got really disaster pneumothorax like tangent pneumothorax and hemodynamic instability, so it might be the issue. So that's my opinion.
I have to comment the last doctor, what he said. I mean, tension pneumothorax, it's a clinical diagnosis. You don't need ultrasound and chest X-ray. There is back triad. The tension pneumothorax, one of the pathology in surgery generally, that can kill your patient during a couple of seconds. So it's mandatory to rule out when you are getting to your patients, there is no tension pneumothorax. Because, I mean, if you are losing 2-3 minutes, patient can die. So we are not talking regarding, I mean, regular pneumothorax. You know, someone has minimal or minimal limitation of, during breathing. We are talking regarding tension pneumothorax. So, I mean, from my point of view, I want to summarize what I'm saying. Okay, the concept must be to do minimal procedures in the field and to get your patient as soon as possible to the hospital. And it's not my opinion. This is the approach in the world, scoop and run, okay, system. So you have to do like Professor Lerner mentioned, if you have this stability of extremity, you can get together, relax, and if you have a dislocation of hand, you can attach your hand to the body of a human, get to vein access, protect your airway, put your patients on ambulance or on the helicopter and get to the hospital as soon as possible.
Okay. Thank you. And the next controversial question, what I would like to discuss is about, we already mentioned it a little bit, but about advanced airway management with endotracheal intubation in the place of accidents. So what could be those situations when you prefer and suggest to do it right there on the street, on the field, in this primary survey stage? And again, advantages and disadvantages of that, and of course your experience. Doctor? Okay, let's continue with Dr. Kakiashvili.
Yes, it's a very good question and very interesting question. So, if you can do airway access by AMBO, not endotracheal intubation, and you are close to your hospital, okay? So there is no indication to do intubation in the field, okay? Because we know all those complications when people are trying to do intubation and reintubation, and they are inflating the stomach, and then patients, they are doing aspiration, and then aspiration pneumonia and all sorts of complications. So at least our approach in ambulance, if you are close to the hospital, okay, so you can protect airway access by AMBO, and then get your patient as soon as possible to hospital. So doctors in good, very convenient environment, emergency room, they can do endotracheal intubation. So sometimes if you cannot do airway access by AMBO, so you don't have any choice, so you have to intubate your patients.
Okay, thank you.
But again, I want to underline this problematic point. What is saving our patients to get them as soon as possible to the hospital, okay?
Okay, thank you. And Dr. Daphne Wilner, what are your thoughts?
So I agree with Dr. Kakashvili. Basically, if the patient can maintain his saturations, then you should, like we said, scoop and run and bring him to the hospital as fast as possible. If you can, if he is not, and you can manage to ventilate him with mass ventilation with an AMBO, then certainly it's taken into account that you don't anticipate any issues along the way if it's close to your hospital. But if you're talking about 30-minute drive, then definitely the patient should be intubated on the scene. Now, I also want to mention that the laryngeal mask airway is a viable option for patients who are not able to be ventilated, certainly are not successful with mass ventilation. Take into account that these patients are most likely not NPL, and therefore they are high risk for aspiration. And as we all know, one can die from aspiration too. So, but again, it really depends how close you are to your hospital and how much your patient is maintaining his saturations. But you should not be spending 30-40 minutes on the field trying to intubate your patient. That definitely not.
Okay, thank you. And Professor Alexander Lerner. Intubation in the scene, what are you thinking?
Okay, sorry. I fully agree with my colleagues, with Daphne and Eli. Nothing additional.
Okay.
Thank you.
Thank you. And now, Dr. Grovenko, your thoughts?
Yeah, it's difficult not to agree with all experts, just we have said. So the problem is here in Latvia, so you need to be trained and skilled in intubation. If you got GCS, let's say 3, and you got dying patients, and that's one story, and you can intubate him. But the problem is if the anesthetic needs to be done, and that's the different level. And most our paramedics not trained to intubate the patient, and this is the problem. So what we can do, yeah, you can bag the patient if you've got time, and you can put the LMA, the second option, and that's probably easiest way to get the airway secured. And of course, if you need to give the anesthetic, so then you just ask for help. And again, it might be timing issues again. So yeah, that's my opinion.
Okay. And next thing I would like to ask is your thoughts about how detailed the inspection should be done in place of accident. And I would like that you keep in mind some factors like hypothermia, poor visibility, and of course uncomfortable work conditions. So what's the workload should be done in the place of scene? You should just grab patient, or there are some things you think should be done? Colleagues from Israel, your thoughts about that?
Can you repeat your question? What do you mean? I mean,
the workload, what should be done in the place of accident? What is the bare minimum you think should be done with the patient in the field, on the street? I don't know where's the patient. What is the bare minimum?
I already said my opinion. As minimum you can do, and take your patient as soon as possible to hospital.
Okay.
All those manipulation, unnecessary manipulation, I'm not mentioning life-threatening manipulation, all those, you know, we saw very good and very nice equipment, you know, all those modern desks and all those stuff. But again, what is saving your patient? Scoop and run approach.
Okay, thank you.
To do minimum in the field and get your patients to the hospital.
Okay, thank you. And finally, about this first part, I would like to talk through some aspects of immobilization. There are two options for immobilization. One of them is vacuum mattress, and one of them is this long immobilization desks. So, pros and cons once again, and which one, in your opinion, is better?
How long time to take the insufflate the vacuum mattress?
About 8 minutes, as we saw.
So there is our answer. I mean, look, it looks very nice. Okay, it looks very fancy. I mean, but there is no need. Again, I mean, you can stabilize minimally your patient. I mean, and take out your patient by ambulance or helicopter to the hospital. And that's my opinion.
Okay, thank you. Dr. Wilner?
This is actually the first time I actually saw a vacuum mattress like that. It's actually quite nice, I have to say. And I also very much like the gurney that is separated and attached. That was quite clever. But again, if it's time consuming, then we want something as quick as possible. I did want to add something regarding the previous topic. I wanted to mention that, remember that multiple attempts by personnel to intubate a patient causes airway edema and causes bleeding, such that when it comes to a skilled personnel like an anesthesiologist, he has difficult conditions doing intubation. So it should be minimal, if certainly when someone is not specialist in the field.
Okay, thank you. And Alexander Lerner?
Okay, vacuum mattress is excellent in the field during transplantation to hospital, but in hospital you need perform exchange of vacuum mattress to local immobilization in case of pelvic fracture with some bandage, with splint for left lower limb, with tibial fracture, as in our case. And according to long spine board, until spine injury is excluded, you need continue with long spine board. You need perform as early as possible total body CT, not X-ray. Today in modern hospital, I think is a gold standard total body CT, not isolated X-ray for cervical spine, for chest, for pelvis. Though after CT you can continue treatment without long board. Thank you.
Okay, thank you. And I have a question for Israel experts. Do you, in pre-hospital stage, do you have these pelvic belts for pelvic stabilization?
Do. Yes, we do.
Yes, we do. Okay. Because in Latvia, we do not have in pre-hospital stage these bandages, and that's maybe one of the reasons about the vacuum mattress. Okay, now to the Latvian experts. About immobilization, vacuum mattress or long immobilization desk. What do you think, Dr. Krupenko?
I think both.
Both.
Because sometimes we have very big patients, and this immobilization in the vacuum mattress inter-hospitally in ER, for example, like our colleague Professor Lerner told us about, it's some difficulties. I don't quite agree with this, because vacuum mattress sometimes is useful to transport on this patient in a vacuum mattress, after that on this spinal board, and especially if the patient is very heavy, we can easily transport him to the CT scan, and after that to the emergency room. So I think both.
Okay, thank you.
And if we were talking about the time, I think well-trained this command on emergency can do it faster, probably in 4 minutes.
Probably. Thank you. Dr. Ivanov, what do you think? And maybe you have, maybe you know something about outcome, if it depends on immobilization technique. Does it change the outcome of the patient?
Outcome, yes. If we speak about, for example, pelvic trauma, of course, if we compress pelvis, it is, could have very severe or better prognosis after such trauma. So we decrease bleeding, internal bleeding, and this vacuum mattress, or also pre-hospital, it can help to decrease bleeding, especially if we don't have this pelvic belt. So I think that if it is possible, we can use this vacuum mattress. And I agree that it's not necessary to have 8 minutes to do this vacuum aspiration.
Okay, thank you. And Dr. Gorovenko?
Here in Latvia, we've got very few tertiary centers where the multi-trauma patient can be managed appropriately. And the vacuum mattress is a very good tool to get the transported patient from the, let's say, from the distant area to the center, which may take an hour and a half or even longer. So that's one thing. Another thing, we do have pelvic belts on a pre-hospital stage on the ambulance, and we will consider that, I'm sure.
Are you saying we have pelvic belts?
We do need have.
We do need, yes,
yeah.
totally agree with that.
Unfortunately, we
Yeah.
don't have it at the time, but we will consider that, I'm sure. Yeah.
Okay, thank you. And now I think we can continue with the second part of the movie. So let's watch it. So the next thing I would like to discuss is this IV access. And in your opinion, where it should be provided in the scene of action or after a patient is being carried into the ambulance car? That's the first thing I would like to discuss. And the second thing is about analgesia before patient's immobilization. So let's once again start with Dr. Kakiashvili.
Your question, what access you have to try to get?
Do we need IV access in the scene of action? That's one question. And the second question is, do we need analgesia? And how can we provide it if we do not have IV access before patient's immobilization?
Yeah, I definitely think you have to get IV access. I mean, 2 largest granula you can put in both hands, okay? And of course, you can use analgesia also through the vein, not IM.
Okay.
And it must be done outside of ambulance.
Okay, thank you.
Vein access.
So you agree that IV access is the procedure you prefer to do in the scene of the action?
Definitely, yes.
Definitely, yes. And the next question is, what kind of medication are you using in the pre-hospital stage for analgesia, for pain?
This is a very difficult question for surgeons. Daphne, can you comment it, please?
Yeah, you can transfer the question to colleagues as well. No
I would
problem.
like to comment. First of all vital signs are done initially on the scene, okay? Which I noticed it wasn't done initially, it was done in the ambulance. That is not what is done here. We do vital signs, saturation, heart rate, and blood pressure, patients connected to an ECG, all on the scene. Therefore, and an IV line is placed on the scene. Then, based on the vital signs that we get, then we decide whether to give analgesia or not. If the patient's got 50 blood pressure, the patient is not going to get analgesia. But if the analgesia that is given is usually fentanyl.
Okay, thank you.
And yes, an IV access on the scene.
Okay, thank you. To our Latvian experts, Dr. Gorovenko, about IV access.
You're absolutely right. So the vital signs needs to be checked first on a scene to the patient, and then during the secondary assessment. So, and that's the different story. In terms of the analgesia, that's a big part of the treatment as well. So you can use fentanyl, either morphine or let's say opioids. Like drugs, so and that needs to be done. So yeah.
Okay, I have one more question.
Yeah.
You are saying that vital signs should be done on the scene of the action, which means blood pressure, cardioscopy, like for electrodes, maybe pulse oximetry. But if it is the winter, they'll have like 3 coats. And you have to undress patient just to put on electrodes to get the blood pressure. What about that? Maybe that's the case when it's better to just immobilize patient and to put it in ambulance.
Well, so if you got pulse, you need at least check the pulse, peripheral or central. So you got peripheral pulse, so you got some perfusion, at least 19 systolic. So it's not that difficult to check the respiratory rate and put the pulse oximeter on a finger. It might be issue with the cold fingers and etc. And we know that, but at least you need to document it. The first vital signs you see the first time on the patient. So that needs to be documented anyway. So.
Okay.
I just wanted to add to what he said is that I agree with him. I agree totally with Dr. Gorovenko, but I don't think any medication is ever given until you have a baseline assessment of your patient. Okay.
Okay. Yes. Okay. And one more question. In Israel, do you have any internal guidelines with this IV access? Do all country paramedics do the algorithm where it should be done?
Can you clarify that?
Yes. Do you have guidelines or any internal rules which is followed by IV access where you do it? In the field or in the car, in the ambulance car?
Definitely in the field. Definitely. No, there is no manipulation in car and helicopter. Even I would like to tell you, okay? If helicopter is flying and there is emergency intubation, there is indication to land down somewhere helicopter, do intubation and then go up.
Okay,
Okay,
thank you.
because believe me, I did my army service in helicopter, okay? There is disaster to do all those manipulation in helicopter. And definitely in ambulance, where ambulancing driving.
Yes,
you know?
I would like to clarify that ambulance car is not driving. Also in Latvia, we are not doing any procedures. Even at the blood pressure management, we don't stand up and work while the car is driving. It's just then the car stops or is on the place and does not move when we are doing some procedures.
I understand your point, but you know, it's a so tiny place in ambulance, you know, in the video, it looks very nice, you know, people are moving very easy, but when you have a super emergency case to do in this tiny place, I mean, all those manipulation, it's not a good idea. So I don't understand what is the problem to do everything in the field near the ambulance. Okay, actually, when we started this discussion, one of the doctor mentions because civilians they are around, I mean, and they don't have to see. Actually, what usually happened in Israel when ambulance is going to the field, when you have any accidents, I mean, any road accidents on, crime accidents, usually police also going with ambulance. It's synchronized and they are doing protection of the field. So there is no civilians there, okay?
Okay, and how about hypothermia or some aspects like if there's a night?
I mean, yeah, it's a very good question and very good point. But you know, as I mentioned, patient must be get to the hospital as soon as possible. So this is a solution of the problem.
I also wanted to, I mean, again, our conditions are probably different than yours. We don't have really, you know, minus 23-degree weather. So it's not something that we need to sort of consider. Though I do want to point out that, I don't know if anybody noticed, the patient, as Dr. Kakashvili mentioned several times, the memorable 8 minutes that it took to wrap him up. But they brought him into the ambulance and it took him a few minutes just to unwrap the patient, which is basically wasted time. So, but yes, we put our IV accesses, as someone who worked in the ambulance in Israel, all IV accesses are placed in the field. Additional IV accesses can be placed in the ambulance, but generally there's got to be one IV access placed in the field.
Okay, thank you.
Yeah, only in the field, and even in Israel Army, IV access is job of paramedic in the field, not in doctor.
Mm-hmm. Okay, and the next thing, after patient is carried into the ambulance car, all team is guided by the team leader, as we saw in the movie, which gives each member a specific task. And my question is, do you have something similar in Israel? Like all members of ambulance cars in Latvia knows where to stand, all tasks he have to do, and assistant knows as well, and driver knows as well. It's like a working mechanism. Do you have something similar in Israel? How to work in such small place, most effective, without mess?
Yes, of course, we do have guidelines. Everyone knows what to do, but finally, everyone is doing everything. You know, I mean, when you have severe trauma. That's what happened in reality. Of course, we have trauma manager in pre-hospital treatment also and inside of hospital, but you know, it's very different from the nice video what happened in reality. Okay.
Don't forget, there's a team leader. There's
Yes.
I mean, there's different hierarchy in the ambulance. I mean, there's obviously the driver, and then there's there used to be a doctor, but then there's the paramedic, and then there's the assistant, and then usually there's a volunteer. So obviously there's a different hierarchy, and the team leader is what assigns everybody a job to do.
Okay, thank you. And now to Latvian experts, any thoughts about the second part and what we just discussed about IV access providing?
Well, the IV access is not the problem. So in real time, it's usually the cannula put on the first when you see the patient, when you assessing him, the patient. The first, the secondary assessment, I think it's done nicely, and the patient was exposed and everything was checked, and they checked as well the GCS, and I think they found that the changes and there's some disaster what we've seen. So, yeah.
Okay, other experts? Do you want something to say about it?
Actually, not much to comment. I think, yes, IV access as soon as possible, and analgesia, of course, and probably, yes, probably, I think everything was okay.
Okay, thank you. And the third part of the movie, which we already watched, so we do not do this one more time. And let's discuss discussing both topics. The first one is about infusion therapy principles. And of course, as all this event, I would like to hear our Israel experts' experience about infusion therapy and how do you manage it in pre-hospital settings.
Ali?
Infusion therapy, what you mean? What kind of liquids we have to give to our patient?
Yeah, what do you prefer if we have a patient with hypovolemia due to bleeding, probably?
Yeah, very nice question. In pre-hospital setting, there is no vasoconstrictors, okay? The liquids we are using, usually it's a ringer lactate, okay? To raise the intravascular volume. Of course, in pre-hospital step, we don't have blood transfusion. Okay, there is no blood on ambulance. That's it.
I think also, you know, in general, we go by the American guidelines, and in the American guidelines, again, we use mostly ringer lactate, and also the main change that I find in trauma now is that we do not overhydrate our patients. Even otherwise, you're just going to be diluting him. You're going to be diluting important coagulation factors, and your patient's just going to bleed more.
Daphna, very good comment. Thank you. This is a very important point to keep patient blood pressure. I mean, around one systolic blood pressure 100, 110. Okay.
Okay, thank you. That's the same how we are doing it. And to our Latvian experts about infusion therapy.
Yeah, we tend to use the normal saline rather than ringer lactate. The first and the second part, if we do think the patient might have internal bleeding, so we tend to not to over fluid, and personally keep trying to keep the blood pressure systolic around 90 and no more. So that's perfectly accepted. So, yeah.
Okay, what is the first volume you are like?
Oh yeah, so in terms of the volume, probably 250 the first.
Yes.
If it doesn't change anything, probably more, but not around the liter or not that much.
Okay,
Yeah.
thank you. And how about our Israel colleagues says that you don't have vasoconstrictors in pre-hospital settings. In Latvia, we do have. Maybe once again I can refer to Dr. Gorovenko, some comments about vasoconstrictors.
Well, I think there is no place for vasoconstrictor during the polytrauma, and that's understandable, and that everybody agrees. If you think the patient might have some septic shock or anything like cardiac problems, then you might give some vasoconstrictors, but that's the different story, really. So, but we still use, yeah.
Okay. And the next topic is tranexamic acid. First question: do you use in Israel in pre-hospital settings the tranexamic acid?
So I can tell you, so I'll answer that question. We do not use it in the pre-hospital setting, but the minute the patient does come and we assess that he's bleeding, he does receive 1,000 milligrams of hexacapone, tranexamic acid, in the emergency room. But the drugs available for the paramedic on the field are actually quite minimal, other than, you know, the resuscitation drugs.
Okay, thank you. Maybe I can ask Dr. Sivanos about tranexamic acid.
Yes, I have only experience in hospital and don't have pre-hospital experience. And we use, of course, tranexamic acid in polytrauma patients. But if it is possible, I think tranexamic acid we can use as soon as possible also. Except we can have some allergic maybe reactions that can maybe difficult to manage in pre-hospital at all. That's why I don't actually, could be one reason why I do not use in pre-hospital at all, yes, but why not actually, yeah.
Okay, thank you. And one more thing, in Latvia, for administrating tranexamic acid, there are two things. There should be patient with high energy trauma and with clinical shock signs. And maybe this is once again a question to the Dr. Gorovenko. Do we need to wait for the shock signs to administer the tranexamic acid if maybe patient has fall from, I don't know, 9th floor?
Where you think the patient might have bleeding, so you can use the tranexamic acid nowadays. So, but that's not the magic drug. So tranexamic acid is very popular nowadays. But personally, I wouldn't wait for shock if you've got the situation where you might use the tranexamic acid. So you can use that. But again, so yeah.
Thank you. Then maybe our Israel experts would like something to mention about...
Sorry, I got interrupted. I would like to mention a little bit, because I did a review on tranexamic acid. In general, you know, most of the review was regarding spine surgery, but again, it looked on in general on tranexamic acid. Your main concern is actually thrombosis, but the incidence of thrombosis is so low. So your chance of the patient having a thrombotic event is quite small, A. B, the doses for tranexamic acid are so variable such that I don't see any really contraindication. And if you have a bleeding patient, to give 1,000 milligrams, we give it for hip surgeries, we're giving it for rhinoplasties, we're giving it for everything practically. And we don't really see complications with it. Therefore, I don't see any contraindication giving a patient who's bleeding in the field a dose of tranexamic acid.
Okay, thank you. And the next thing, I think very interesting, tangent pneumothorax. First, my question is to all our colleagues, how often you have personally experienced it? And what was the case and how did you manage it? Not regular pneumothorax, but tangent pneumothorax. Maybe Professor Alexander Lerner can share some of experience about tangent pneumothorax.
I'm an orthopedic surgeon in our country. This is job of my colleague Eli.
Okay,
Eli, please.
let's refer to the Eli. Okay.
Okay, as I mentioned, tension pneumothorax, it's a super emergency in surgery. Okay, as I mentioned, it's a clinical diagnosis. How often we see tension pneumothorax? Luckily, not too much. Okay, so we know this bacteria, yeah, enlargement of jugular, okay, the low arterial blood pressure, tachycardia, okay, so it's a clinical diagnosis. There is no reason to wait to ultrasound and X-ray, and you have to put a chest tube, not needle application. We don't like needle application because there is a lot of complication during needle application. Even in the field today, I mean, even in the war field, I mean, battlefields, there is an approach to use chest tube, not needle application. Now, if you have situation in battlefields when everyone is shooting around and you cannot do like this procedure, we also have statistics to insertion of chest tube. It's around procedure around 3 minutes. I mean, we have our own statistics, okay? So the approach today, do not use needle application and get chest tube if it's possible. If you don't have any choice, so put needle application. If you don't see improvement of patients, you can do additional needle application. And sometimes we are getting patient in emergency look like umbrella, you know, a lot of needle applications. So we have to be very careful regarding this procedure. People, they think that it's very easy procedure, needle application, but we saw a lot of complication, okay? And we saw sometimes that people, they did needle application in the field and they did not have experience, and they saw the resolved problem, and they bring patient semi-tension pneumothorax, okay? So there is a fully agreement in Israeli surgical community today to use chest tube, not needle application. If you don't have choice, you can do it.
Okay, thank you. And how about in Latvia? About tension pneumothorax? Dr.
Yes, I
Ivanov?
can comment. Of course, luckily, of course, we don't see very often this tension pneumothorax, but if we see it's an emergency situation, and of course it's hospital, we placed chest tube. I don't know if we have possibility to place chest tube in ambulance. Yes, I don't know. I think not. Yes. And yes, probably we can take your experience, and probably we can also teach ambulance to place thoracostoma, yes, chest tube inside, yes, probably.
Yeah, I must mention our paramedics, really, they are very experienced to put chest tubes. I mean, really, I mean, they are doing very great job, and I don't remember last time when we get patient in hospital with needle application, okay?
Okay.
I do want to add, though, that very often tension pneumothorax is a misdiagnosis. Your patient's bleeding, he's tachycardic, he's hypotension, so you're thinking, oh, he's just bleeding more, and people tend to overlook. You have to have a high level of suspicion for a tension pneumothorax.
Okay, thank you. The next emergency situation is brain herniation, and I think this is a question for Daphne Wilner. As you specialized in neuroscience and neurotrauma, maybe you can share some interesting facts or experience about it, about brain herniation. And once again, my question is, if it happens in pre-hospital stage, how do you manage it, or you do not manage it?
If you have a patient who has Cushing's triad, in other words, he's bradypneic, he's bradycardic, and he's hypertensive, then you have to suspect, certainly, obviously the mechanism of the injury, you have to suspect herniation. And in a pre-hospital setting, other than hyperventilation, there is really not much more that you can do, and just get him to the hospital as quick as possible. If you're on your ambulance, there's mannitol, then certainly that should be a drug, a fluid that's given, or hypertonic saline. Most ambulances do not have that, but certainly he has to be quickly ventilated, mass ventilation or intubated, whatever is quicker, and hyperventilated. That is the only thing that's going to save your patient in the pre-hospital setting.
Thank you. Dr. Gorovenko, can you share?
There is nothing much you can do. So if the patient needs to be intubated, the patient needs to be secured to the airway. And what we can do more, probably just we use the mannitol, which is probably the equivalent to natrium hypertonic solution. So, and that's all. So, and just get them to the emergency department as quickly as possible.
Daphna, do we have monitor in the ambulance in Israel? I'm not sure.
No, we do not have. We do not have mannitol, and we do not have hypertonic saline.
Hypertonic saline, yeah.
Okay, thank you.
I do want to remind, certainly the attendees that mannitol has its problems too, especially if in a bleeding patient, especially when you're talking about multi-trauma.
Okay, thank you. I think that was the last emergency case because we have already talked through any other situations. Maybe our Israel experts, there's something you would like to add. What do you think about our discussion?
Well, I want to actually thank you guys. Brought up a lot of very, very important points. Again, I think certainly one has to take into account an elderly patients that beyond they might be bleeding, but you have to take into account cardiac issues that might be happening at the same time, and that's sometimes missed also. You have to have a high level of suspicion in a lot of these multi-trauma cases for a lot of different scenarios. Whether it be a pelvic fracture or an internal bleed or a tension pneumothorax, you really have to suspect everything and you really have to be open to everything.
Okay, thank you. And Professor Alexander Lerner, anything you would like to add for our discussion? No.
All is good. Maybe in the start of video, we look the people going to patients with facial mask, with cervical collar. Maybe we need in the ambulance some small bag with these basic things for severe trauma: cervical collar, facial mask, 2-3 bandage.
Okay.
I would like to
It
ask
may performs to make the long story short.
I would like to ask the Latvian colleagues, do you have muscle relaxants in your ambulance?
Yeah, we do have. So we have two types of muscle relaxant. Succinylcholine for the first one, and we got available rocuronium and atracurium as well. So if we do need. Yeah.
So who is giving that? The paramedics?
No,
or the doctor?
Just some extra doctor who run normally a fast response car. So actually the paramedic, they ask for help if they need intubated the patient or do if they think they need to do the anesthetic. So and then just doctor arrive and do anesthetic and intubation.
Because we do not have muscle relaxants in our ambulances. I think maybe from the concern that we will get in a situation where we cannot ventilate or cannot intubate.
Yeah, we don't have either on normally on ambulance. We're just the special cars. Yeah.
Okay, thank you. Anything Latvian colleagues would like to mention?
Well, thank you very much. I think it was a good and very nice chat, and thank you for good discussion and quite interesting. Thank you.
Okay, thank you. And I think we can continue with the questions from the chat, but as I'm seeing now, there's no questions from the chat. And Dr. Gorovenko would like to say some few words about all this event.
Thank you very much for everybody. Thank you very much, dear colleagues, and especially my great greeting to Professor Lerner. I remember your terrible presentation I seen 3 years ago. My greeting, Professor.
Next month I shall be in Latvia. In Riga next month.
Oh, nice, 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 nice. We will see.
Yeah.
For us, was very important to know your opinion about polytrauma patient management, and we got a lot of differences. We've heard a lot of controversial details, and I think it's very important because you have some experience, you have some tradition, depends on weather, depends on culture, tradition, etc. But I hope that you get some information about our medicine in Riga, in Latvia, and thank you very much, everybody. Thank you very much, my excellent team, Dagnia, Erwin, and students. Thank you very much. And see you soon. No, Professor Lerner next month in Riga, but see you soon in Israel. Thank you.
Yeah.
Thank you.
Thank you very much.
Thank you, Victor. Dear colleagues, experts, and all listeners, I want to thank you all. Of course, special thanks to our experts both from Latvia and Israel. It was great experience exchange, and I think we all got some new tips and tricks we can use in our daily practice. Special thanks to my colleagues for this project management, and I wish you a great rest of the day, and never stop learning, never stop growing. Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.
Wow, yes. Wow, yes.